A 63-year-old man presents to your office complaining of worsening shortness of breath over the past 1 year. You know that this patient has smoked 2 packs of cigarettes a day for the past 45 years. So there is a long smoking history in this case. As you are talking to the patient, you notice that he is using his accessory muscles of respiration to breathe, that his chest is barrel shaped, and he is breathing carefully through pursed lips. Using a spirometer, you determine that he has a decreased FeV1-FAC ratio and increased total lung capacity. You tell the patient that it is imperative that he stop smoking and prescribe him a tiotropium inhaler. So tiotropium inhaler you are indicating for this patient. FeV1-FAC ratio decreased, which is a typical picture of chronic obstructive pulmonary disease. Increased total lung capacity can also be seen in chronic bronchitis, but increased total lung capacity is a typical picture of emphysema. And he is also using accessory muscles of respiration and also pursed lip breathing. Long smoking history, that is 45 years. Age is 63. So because the age for the chronic bronchitis is approximately 45 and the age for the emphysema is greater than 50, maybe up to 65 or 70, because after that the next stage is called as bronchogenic carcinoma. So this is the case of emphysema. So what is the etiology? Emphysema is associated with smoking as well as hereditary alpha-1 antitrypsin deficiency. So these are the 2 important etiological factors responsible for the development of emphysema. We know that emphysema is a component of COPD, which is chronic obstructive pulmonary disease, along with asthma, bronchiectasis, as well as chronic bronchitis. Other 3 also comes under COPD. Now let us see what is the pathology and pathophysiology. If you see the functional unit of the lung, so what exactly is the functional unit of the lung? If you see the overall respiratory tract over here, from the trachea, bronchi, bronchioles, and terminal bronchioles, respiratory bronchioles, alveolar duct, and finally we reach alveoli. So acinar involves respiratory bronchioles, alveolar duct, as well as alveoli. So acinar is the one typically involved in the emphysema compared to that of other bronchopulmonary tree. So this is what you need to remember. So acinar is the one anatomical location which is typically involved in emphysema. Now, emphysema is characterized by the loss of lung parenchyma, typically because of the loss of elastic tissue, mainly by the destruction of the alveoli. So whenever there is a destruction of the alveoli, along with the loss of elastic tissue, that is loss of lung parenchyma, there will be a permanent dilation of air spaces, and there is a typical loss of elastic recoiling capacity of the lung. Because of the elastic fibers are damaged, lungs cannot recoil. That is the reason the patient exhibits with barrel-shaped chest. So if we see the enzymes, elastase is the enzyme which can destroy elastin in the alveolar walls. But this elastase is always neutralized by alpha-1 antitrypsin deficiency. So if there is a deficiency of alpha-1 antitrypsin, elastase cannot be destroyed, because alpha-1 antitrypsin is normally produced by the liver. It can also be produced by the macrophages. It is seen in the serum. It can also be produced by the neutrophils also, but it is typically produced by the liver. So smoking is the one which can inactivate alpha-1 antitrypsin. Not only it inactivates alpha-1 antitrypsin, smoking also attracts neutrophils as well as macrophages, which can secrete more elastase. So here the severity is much more with smoking associated emphysema when compared to that of alpha-1 antitrypsin deficiency, because in alpha-1 antitrypsin deficiency, concentration of the elastase is not increased. Concentration of the elastase is intact, because of the deficiency of alpha-1 antitrypsin, elastase cannot be inactivated, and this elastase is destroying the elastic fibers in the alveolar walls. But in smoking, what's happening is there will be increase in the elastase concentration because of the activation and attraction of the neutrophils and macrophages, and at the same time inactivation of the alpha-1 antitrypsin deficiency. So destruction and damage is much more severe in smoking associated emphysema. So that's the reason the most accepted theory for the pathogenesis of emphysema, now whatever I explained to you, is a protease and antiprotease mechanism. Maybe the protease concentration is high, that is elastase, or maybe antiprotease, that is alpha-1 antitrypsin, is low. So that's the reason the most accepted theory for the pathogenesis of emphysema is the protease and antiprotease mechanism. So here if you see, mainly if it is a smoking associated emphysema, the oxidant and antioxidant imbalance also plays a major role in smoking related emphysema, because there will be a development of reactive oxygen species during smoking. Whenever there will be an increase in the free radicals, that can also attract more macrophages as well as neutrophils to increase the concentration of elastase locally. Even that is considered to be an important causative factor for the destruction of alveolar walls along with its elastic fibers. So now, what is alpha-1 antitrypsin? As I already mentioned, alpha-1 antitrypsin is actually normally present in the serum produced by the liver, tissue fluids, as well as macrophages. And we know that it is a major inhibitor of proteases, particularly elastase in the alveolar walls, and it is also secreted by the neutrophils during acute inflammatory process. So any patients with a genetic deficiency of antiprotease alpha-1 antitrypsin, which is approximately seen only in 1% of all the patients with emphysema, have markedly enhanced tendency to develop pulmonary emphysema, remember. So only in 1% of the patients of emphysema you will see antiprotease alpha-1 antitrypsin deficiency, which is typically seen. But if you see all the different types of emphysema, smoking increases the risk further, whatever the type may be. So that's what you need to know, because not only smoking, along with it inhaled pollutants, all these can cause like ongoing accumulation of inflammatory cells, because whenever there are like continuous irritants which are flowing into your lungs along with smoking as well as with other pollutants, there is no rest for the neutrophils as well as for the macrophages, because there is a continuous inflammatory process. Whenever there is an ongoing inflammatory process, it releases elastase continuously, and also because of smoking, oxidants and reactive oxygen species are also produced continuously. These are the one which can destroy alveolar walls. So there is a loss of elastic tissue in the walls of the alveoli, mainly because of unopposed action of the elastase, which mainly causes the respiratory bronchioles, which means the acinar part, collapse during expiration. Because collapse during expiration, persistently breathing, what you can see in emphysema, and this leads to the functional airflow obstruction, and this functional airflow obstruction, but there is no mechanical obstruction, because mechanical obstruction is typically seen in bronchiectasis, which is a part of COPD. There is a functional airflow obstruction, but there is no mechanical obstruction like a tumor or any other conditions. So now let us talk about gross findings. Overall, whatever may be the type of emphysema you see, there will be irreversible enlargement of air spaces, and there will be a destruction of the alveolar walls. Remember that irreversible enlargement of air spaces are typically distal to the terminal bronchiole. distal to the terminal bronchiole, and the destruction of the alveolar wall, and there will be without obvious fibrosis. There is no obvious fibrosis, but there is a destruction of the alveolar wall because of too much action of proteases, that is elastase, and there is a bullous emphysema which is seen because there are large subpleural bleps or bullae which are seen, and these spaces are always greater than 1 centimeter, what you can see in this picture, and these bullae are large dilated air spaces that bulge out from beneath the pleura. So that's why the bullous emphysema is also the typical picture which can be seen in any other type of emphysema. So this is the gross finding, and if you see another gross finding picture, so the cut section of the lung on the left side, this is the normal lung, what you can see. There are no air spaces, dilated air spaces, what you can see over here. But if you see here, the typical dilated air spaces or the typical picture of emphysema. So cut section of the lung showing the dilated air spaces when compared to that of the normal lung. So this is how you can identify the gross pathology of emphysema. So now let us see what are the characteristic pathological changes in emphysema. There are like 4 important points what you need to remember over here. First is the destruction of septal walls of the alveoli, or in simple language you can say the destruction of the alveolar walls, and these alveolar walls are nothing but forms septum between each alveoli, and loss of elastic recoiling capacity of the lung because of the damage to the lung parenchyma, because of loss of elastic fibers, and not only that, because of septal walls are involved along with alveoli, there will be destruction of the vascular bed. And at last, because of this pathological phenomena, fusion of the adjacent alveoli with one alveoli producing large abnormal air spaces. These are the one responsible for the development of bleps or bullous formation. If I repeat once again, there will be destruction of the alveolar walls, which are nothing but called as the septal walls. If the wall between two alveoli is gone, then two balloons will combine to form large abnormal air spaces called as bleps or bullous, and there will be loss of elastic recoiling capacity and destruction of the vascular bed. So all these 4 are the characteristic pathological changes which are seen in emphysema, whatever may be the type of emphysema. Remember, there are like different types of emphysema we are going to discuss now. Whatever may be the type of emphysema, all the 4 characteristic features you can see, but the degree of severity may differ in each type of emphysema. So now let us talk about 4 different varieties. So emphysema is classified mainly according to the anatomical distribution within the lobule. So depending on that, Centri acinar, pan acinar, paraseptal, and irregular. So here the first one, which is Centri acinar and pan acinar, if you see, most common forms, out of which Centri acinar is considered to be the most common form, constituting like approximately 90% of all the types of emphysema. And if you combine Centri acinar and pan acinar emphysema, constitute about 95% of clinically significant cases. And remember, both Centri acinar and pan acinar emphysema can cause clinically significant airflow obstruction. So that's why, remember, in the exam also 95% of the cases they'll give you about Centri acinar and pan acinar, and the rare forms are paraseptal and irregular. So remember, irregular is also important because irregular, most common, clinically insignificant, they'll ask you. So which emphysema is clinically insignificant? Irregular should be your answer. And remember that irregular is the most common histological type. There are 2 points you need to remember for irregular. It is most common, clinically insignificant, and it is the most common histological type. And if we talk about Centri, acinar and pan-acinar, these are the most common form, constituting more than 95% of clinically significant cases, and both can cause clinically significant airflow obstruction. Now let us move on to our each different type. So first one is called as Centri acinar emphysema, which is also called as Centri lobular emphysema. So in this, mainly respiratory bronchioles are affected, which are the central or proximal parts of the acini. That's why we are calling it as Centri lobular, depending upon the anatomical location. So respiratory bronchiole, because always I told you that acinus is the one which is involved. So respiratory bronchioles are affected. Anatomical location is central or proximal parts of the acini. So in this Centri lobular emphysema, distal alveoli are spared. There is no pathology in the distal alveoli. So here both emphysematous and normal air spaces exist within the same acinus as well as lobule. This is very important point to be noted, because some of the alveoli are damaged, undergo destruction of the alveolar walls. So those damaged and destructed alveoli are nothing but called as emphysematous air spaces, and the normal air spaces, which means like normal alveoli and normal alveolar walls. So both exist within the same acinus as well as the lobule. And mainly in the Centri acinar emphysema, upper lobes are the one which are particularly involved, and mainly the apical segment of the upper lobes. Remember this point. In the Centri acinar emphysema, apical segment of the upper lobes are particularly involved in this type. And mainly the Centri acinar emphysema, if you see the etiology, it is seen in heavy smokers. So the most common cause for the Centri acinar emphysema or the Centri lobular emphysema is heavy smoking, and also associated with the chronic bronchitis, or we can say progression of the chronic bronchitis can cause Centri acinar emphysema, because chronic bronchitis is also associated with smoking. That's why I told you that the age for the chronic bronchitis is approximately 45 years, and if the patient still did not stop smoking, then progressively it may lead to emphysema, that is Centri lobular type of emphysema. That's why smoking is underlying risk factor for both chronic bronchitis as well as Centri acinar emphysema. So because of smoking is a risk factor, as I told that this coal tar, whatever which is coming from the smoke, can attract neutrophils, macrophages, and it can also produce the reactive oxygen species that can cause a free radical mediated injury. So neutrophils and macrophages are considered to be the most common inflammatory cells which are seen in this type. Now let us move on to our histological picture. See, this is the normal lung, what you can see over here microscopically, where the alveolar walls are thin and delicate, right? And the alveolar walls are also like closed, not so open. Only few are like open, what you can see over here, but majority are like closed. But you can see very clearly that the alveolar walls are thin as well as delicate over here. But if you see the emphysematous pictures, there are like damage to the alveolar walls. You can see like very large air spaces, which is nothing but called as dilated air spaces. When compared to that of, if you compare once again this picture, there are like no large air spaces, right? Because the alveolar walls which are thin and delicate, and the air spaces which are very small. But because of the damage to the alveolar walls, because one alveoli combined with another, the air spaces will become larger. So this is the loss of alveolar walls of the emphysema, and too much dilation of the air spaces, which is a typical picture of this type of emphysema. So this is the microscopic picture what you need to remember for this case. So here nicotine is the one which is present in cigars, act as a chemoattractant, as I mentioned, for both of the neutrophils as well as macrophages. And macrophage elastase is resistant to alpha-1 antitrypsin compared to that of the neutrophil elastase. Remember, elastase is the same, but macrophage elastase is resistant to alpha-1 antitrypsin. So even though alpha-1 antitrypsin is present in normal amounts, but the recruitment of the macrophage can produce elastase, which is resistant to alpha-1 antitrypsin. So what exactly we need to understand from this is, neutrophil can also produce elastase, but neutrophil is a typical cell of acute inflammation, approximately for 3 days. But if the person is having a history of chronic smoking, remember macrophages are the predominant cells when compared to that of neutrophils. That is the reason macrophage elastase is resistant to alpha-1 antitrypsin. What happens is the elastase cannot be inactivated by alpha-1 antitrypsin, which can damage and destruct alveolar walls, responsible for severe type of emphysema, which is Centri lobular. And another point, if you see, the smoke particles can also accumulate, typically at the bifurcation of the respiratory bronchioles, and that is the reason, because they are stuck at the bifurcation of the respiratory bronchioles, they cause Centri acinar type of emphysema. That's why the anatomical location of the Centri acinar is because of the smoke particles accumulated the bifurcation of the respiratory bronchioles. And if you see the oxidant mechanism, the antioxidant imbalance because of too much production of antioxidants and too much production of oxidant reactive oxygen species and antioxidant mechanism is not present. So that's why antioxidant imbalance also plays a major role in the pathogenesis in smoking related emphysema. So all the 3 points you need to remember for pathophysiology. One is nicotine, which attract chemo, which is a chemoattractant for both the neutrophils and macrophages. And macrophage elastase is resistant to alpha-1 antitrypsin, which is one mechanism. All coexist, remember, in this type of emphysema. It is not like individually is the risk factor. All together can cause severe type of emphysema. The smoke particles which accumulated the bifurcation responsible for the anatomical location of the emphysema, which is Centri acinar. And if you see the exaggerated cases like antioxidant imbalance, which also plays a major role in pathogenesis in smoking related emphysema. So this is about Centri acinar emphysema, first type. And the second one is the pan-acinar emphysema, which is also called as pan-lobular emphysema. So why we are calling it as a pan-lobular? Again, as I mentioned, these emphysemas are categorized based on the anatomical location. So acini from the level of the respiratory bronchiole to the terminal blind end of the alveoli. So entire acinus is involved. That's why it is called as pan-acinar or pan-lobular. Not just the respiratory bronchiole which is involved, right, in the previous case. But here, acini from the level of the respiratory bronchiole, alveolar duct, alveoli, till the blind end of the alveoli are affected. That is the reason the entire acinus is involved in this type of emphysema. Whenever the entire acinus is involved, not just the respiratory bronchiole, alveoli undergo like enlargement, acinus are uniformly enlarged because of it is a pan-acinar type, and it is more commonly seen in the lower zones and most severe at the base of the lung. But the previous one, more commonly seen in the upper lobes, more commonly at the apical areas of the upper lobes. But this one, more commonly seen in the lower zones or lower lobes, we can say most severe at the base of the lung, pan-acinar emphysema. And this type is not associated with smoking. This type is associated with the congenital alpha-1 antitrypsin deficiency. That's why, as I mentioned, the Centri acinar emphysema and the pan-acinar emphysema constitute about 95% of the cases of emphysema. And here, neutrophils are the major inflammatory cells even in this pan-acinar type of emphysema. So now the next type is called as a distal acinar emphysema, which is also called as the paraseptal emphysema. Why we are calling it as distal? Because again, because of anatomical location, the distal part of the acinus is involved, which means the proximal part is spared. So here, whenever we are talking about the distal part of the acinus, always remember that the distal part of the acinus is close to the margins of the lung. Whenever we are talking about the margins of the lung, which is adjacent to the pleura. So that's the reason emphysema is adjacent to the pleura along the lobular connective tissue septa, that is at the margins of the lobules, adjacent to the areas of fibrosis, scarring and atelectasis. So at the margins of the lungs, you can see because of it is distal, adjacent to the pleura, that is the reason. At the margins of the lobules, adjacent to the areas of fibrosis, scarring, atelectasis is typically seen in the distal acinar type of emphysema, and it is more commonly seen in upper half of the lungs. And remember that the distal acinar emphysema is the most common cause of, or we can say the most common cause for the spontaneous pneumothorax in young adults. So after distal acinar type, let us move on to the next one. It is called as irregular emphysema. In the irregular emphysema, you cannot exactly say the anatomical location because it may be Centri, it may be pan, it may be distal. So it's all over the place. That's the reason we are calling it as irregular emphysema. So here airspace enlargement is seen with fibrosis. Acinus is irregularly involved and always associated with scarring, and mainly occurs in small foci. And remember, as I already mentioned, irregular type is clinically insignificant and it is histologically more prominent type of emphysema. So now we discussed about various different types of emphysema. Now let us move on to our clinical manifestations. So if you see the clinical course, symptoms appears only after the loss of 1/3 of the functioning pulmonary parenchyma, which means whenever there is a destruction of 1/3 of the lung parenchyma with its associated elastic fibers, then only you will see symptomatology. That's the reason whenever the person is progressing towards emphysema from chronic bronchitis, which is at the age of 45, and when he is progressing towards emphysema approximately within a span of 5 to 10 years, the only symptoms what he can experience is the symptomatology of the chronic bronchitis, but not the severe symptoms of emphysema. That's why symptoms appear only after loss of 1/3 of the functioning pulmonary parenchyma, and dyspnea is considered to be the first symptom of emphysema. Anyway, dyspnea is also a symptom of chronic bronchitis, and cough is also a symptom of chronic bronchitis, and expectoration, which is seen with cough, is also seen with chronic bronchitis. May not be a classical typical picture of emphysema because it may be a progressive symptom from chronic bronchitis towards emphysema. And weight loss is common, because which is not common in chronic bronchitis, but weight loss is common in such cases of emphysema. And there is a barrel-shaped chest. Remember that barrel-shaped chest is typically seen in emphysema, but if you talk about the total lung capacity, there is a little bit increase in the total lung capacity in chronic bronchitis, because even in chronic bronchitis, there's a little bit loss of lung parenchyma as well as elastic fibers. That's the reason TLC is like a little bit increased in chronic bronchitis, but it is insignificant. But in emphysema, it is more significant because barrel-shaped chest, it is typically because of too much increase in the total lung capacity. And that is the reason the patient sit forward in a hunched over position, and breaths to pursed lips because of like a functional obstruction. So the key diagnosis in such cases is impaired expiratory airflow. That's why remember we said it is a functional airflow obstruction during expiration. That is the reason it is an impaired expiratory airflow, and it is best measured through spirometry, and the FeV1 FVC ratio is decreased not only in emphysema but all other cases of chronic obstructive pulmonary diseases. So what are the complications? Remember, there are like various complications what we are seeing over here, like cor pulmonale, spontaneous pneumothorax, right? And chronic respiratory failure, hemoptysis, acute bronchitis, pneumonia, all are seen. The most common complication, because all the complication may not be seen in all the patients of emphysema, even though it is a Centri acinar emphysema, even though it is a severe types of emphysema, cor pulmonale is considered to be the most common complication, because cor pulmonale is seen in approximately greater than 70 to 90% of the patients of Centri acinar emphysema when compared to that of the other types of emphysema. Even in other types of emphysema, other complications like spontaneous pneumothorax, chronic respiratory failure, hemoptysis, all these are rare when compared to that of the cor pulmonale. That's why whatever may be the type of emphysema you see, cor pulmonale considered to be the most common complication. So here, okay, everything is good, but what is the cause of death in emphysematous patients? It may be because of coronary artery disease. Typically, it is because of the respiratory failure, and maybe because of the right ventricular hypertrophy, because just now we studied cor pulmonale is considered to be the most common complication. So right-sided heart failure may be the cause of death, or it may be because of the massive collapse of the lungs, as we mentioned, atelectasis, secondary to the pneumothorax, that is spontaneous pneumothorax in younger adults, what we mentioned, atelectasis, massive collapse of the lungs may be the cause of death. So all these four are the cause of death in emphysematous patients. So now there are like, if you, after talking about the cause of death, there are like other forms. The first one is the compensatory hyperinflation. Following unilateral pneumonectomy and lobectomy, there is a compensatory hyperinflation which is seen, which is also called as compensatory hyperinflative emphysema. And in some conditions, there is a obstructive overinflation. So which means subtotal obstruction of the airway by the tumor or a foreign object can cause obstructive overinflation. This is another type of emphysema which is mainly does not come under like pathological forms, but we can say other forms. One is the compensatory hyperinflation type of emphysema following unilateral pneumonectomy or lobectomy. Another type is the obstructive overinflation, which is mainly seen during like subtotal obstruction of the airways by a tumor or a foreign object. Or congenital lobar overinflation is also another type which may be seen, because it is congenital lobar overinflation, which may be seen in infants, probably resulting from hypoplasia of the bronchial cartilage. Remember, hypoplasia of the bronchial cartilage can cause congenital lobar overinflation in infants. And the last one, if you see, it is the interstitial emphysema. So this entrance of the air into the connective tissue stroma of the lung can produce interstitial emphysema, because air should present in the alveoli. Whenever the entrance of the air from the alveoli into the connective tissue stroma of the lung, so mediastinum or subcutaneous tissue, example like chest wounds, fractured ribs that puncture the lungs, or like premature children on PPV, adults on artificial ventilation, all this can develop interstitial emphysema. So these four types are considered to be the other forms of emphysema: compensatory hyperinflation, obstructive overinflation, congenital lobar overinflation, interstitial emphysema. These four are the other forms of emphysema. Now, If we talk about imaging is very important because already we saw in gross pathology there is a bullous formation, right? So there is a hyperinflation with the bullous formation within the lungs with a flattened diaphragm on the chest X-ray, which is very, very important point to be noted. So flattened diaphragm on the chest X-ray. So what are the lab findings? Because already the lungs are overinflated, which cannot recoil properly, patient inability to take oxygen efficiently because already there is too much air which is present, so already the lungs are overinflated. There's the reason extra oxygen which cannot come into the lungs. There's the reason the patient may develop hypoxia, and there will be an increased residual volume because of overinflation, and there will be an increase in the total lung capacity. And the typical picture of COPD is decreased in FAV1 FVC ratio. So this is what you need to remember for lab findings. So what about the treatment? If it is a Centri acinar type, smoking cessation is the only treatment. Along with that, for other types, you can give oxygen bronchodilators as well as inhaled steroids for different types of emphysema. So we know that emphysema is a chronic obstructive pulmonary disease. And one important point I want to tell to you over here is hereditary alpha-1 antitrypsin deficiency also causes hepatic cirrhosis. Even though it's an extra point, just you can note down. Hereditary alpha-1 antitrypsin deficiency also causes hepatic cirrhosis. So this is the case of emphysema.